start, I would want to answer one part of the question that Vishnu Kumar sir had asked. That first, which device is the best to administer oxygen? Sir has already cleared it that especially patient who come to us, venturi mask is the best. Then it will depend on the requirements and pressures we give to them. Second is when to dispose of the disposable things. So when it is visibly soiled, definitely we will dispose it. Second is specifically for nasal cannula, there is a color coding. The normal color is white or green. So the moment you see that the color is changing towards pink, it means you have to change it. Very often we see that the color has changed to pink, in spite of that we are using the mask. So a pink color indicates that the mask has had its life, you have to, the cannula, you have to change again. Okay. Now coming to domiciliary oxygen therapy. So with domiciliary oxygen therapy, we mean that under what circumstances will we be giving oxygen to the patients at home. So there are various types of domiciliary oxygen therapy. We will primarily be targeting long-term oxygen therapy. That is used in cases of chronic hypoxemia like COPD, terminal stages of ILD and all. Here we give oxygen usually on a low flow around 2 to 3 liters per minute for at least 15 to 16 hours a day, which ensures that we are covering 8 hours of sleeping time. Night time coverage is there. The other types are ambulatory oxygen therapy. It is for people who So ambulatory oxygen therapy is for people who are usually not hypoxemic at rest, but they develop hypoxemia during exercise or usual day-to-day activities. So these people get oxygen mainly during exercise time and daily activity time. The third type is nocturnal oxygen therapy, which is given, as the name suggests, only overnight. No oxygen is given during the day. Then there is something called short burst oxygen therapy. This is controversial. Where brief and intermittent oxygen on an as needed basis is given in the absence of hypoxemia. Then there is something called palliative oxygen therapy. Again, this has got some issues, some controversies. It is given for relieving breathlessness in advanced or life limiting diseases in the absence of hypoxemia. We have patients of lung cancer or other cancers who are breathless even when you see that the saturation is maintained. And psychologically or due to other causes, they feel better once you apply oxygen. So as we do not expect the patients to last very long, so the adverse effects of oxygen takes a back seat. So those patients can get oxygen, which is called palliative oxygen therapy. Now, as our primary discussion was LTOT, long-term oxygen therapy, so we'll go into the indications. First is advanced COPD. So which advanced COPD cases will we give oxygen? So we'll need to evaluate the patient. ABG is the primary test which we'll do. Other tests we'll discuss what we need to do. So first is at rest we do a ABG. We see the partial pressure of oxygen in the blood. If it is less than 55 millimeter of mercury, or if the saturation is less than 88%, when the patient is at rest, then we decide about giving domiciliary oxygen. Second is similar patients when the saturation is little higher, 89% or more, and PaO2 is also high, 59 or more, but there is evidence of right heart failure, cor pulmonale or polycythemia. Under such circumstances, because we know that the patient is developing features because of hypoxemia, so we give them oxygen even when the saturation is on the little higher side. The target hematocrit for such patients is 55%. It has been seen that LTOT in a case of terminal COPD has got survival benefit. There is improvement in the quality of life, improvement in depression, cognitive function, exercise capacity, and it has been seen that it reduces hospitalization rate too. But again, as Sir was saying and Dr. Mitra was saying, that we have to ensure that the oxygen that we deliver is as per the SpO2. We do not give more oxygen because then there will be issues of carbon dioxide retention and type 2 respiratory failure. The other indications for LTO2 is ILD. There is no randomized controlled trial which shows that yes, LTOT is indicated in ILD, but we can give extrapolating the results of COPD, considering the fact that complications associated with hypoxia will be less, like development of pulmonary hypertension and all. Similarly, in cases of pulmonary hypertension with a background of COPD, yes, LTOT has a role, but other causes of pulmonary hypertension, it's controversial. We do not have a proper RCT, especially in pulmonary hypertension with non-COPD causes, cystic fibrosis, and sometimes in advanced cardiac failure also we use oxygen, but again we do not have much evidence to use it. We are giving oxygen considering the fact that there may be some reduction in complications which might occur due to tissue hypoxemia, but again no conclusive data. So how do we evaluate people receiving LTOT? So first is we require a detailed history, including a history of smoking. We know COPD patients, most of them they might have spoken in the past, but the important thing is, do they continue to smoke? If they do, then we will not be giving them LTO2. LTOT, the risk will be fire hazards. We have had patients in hospitals, especially in government hospitals, who have smoked despite of the fact that they were in oxygen, and then we have had burn injuries. Anybody from national here? Okay, very junior. We had one case in 2009 and it was a big hue and cry at that time. Now other examinations that we have to do is, we cannot miss features of polycythemia, edema and cyanosis, because as discussed, polycythemia will be directing us to start LTO2 at a lower saturations. Blood investigations needed will be CBC to look for hemoglobin and polycythemia to rule out infections, ABG to look for SaO2 and PaO2. Radiologically, we will be asking for a chest X-ray and a HRCT thorax to rule out other causes of hypoxemia. We will also be requiring ECG, echocardiography with assessment of pulmonary artery pressure. Now we do not have anybody from cardiology here. The problem is, physicians, especially respiratory physicians, they are more concerned about the right side of the heart, and cardiologists are more concerned about the left side of the heart. So very rarely in all the hospitals, including Narayana, will get mention of PAP unless there is a proper pulmonary hypertension. But I'll be happy if they start reporting it in every cases. Now what are the contraindications and what precautions we need to take for long-term oxygen therapy? So patients who continue to smoke, they don't deserve oxygen, we won't give them oxygen, okay, unless they stop it. Other precautions to be kept in mind is fire hazards. So the oxygen concentrator or the oxygen source should be kept at a distance from oxygen from kitchen and electrical sources and all, because of the risk of fire hazards. So what are the typical routes for LTOT? So as Dr. Mitra had discussed, I will not go into that. I just mentioned we use nasal cannula, we use simple oxygen masks, sometimes Venturi mask and other interfaces. The problem is, the oxygen supply devices that we have at home is usually a small cylinder or a oxygen concentrator. It cannot produce a high volume of a high quality oxygen. So Venturi masks practically is out of question. We use, usually the thing that is used is nasal cannula. So what are the complications? First, interface related, the device that we are using to give oxygen, that can cause skin irritation, bruise, nasal bleed, nasal crusting and all. Oxygen related problems, like it was discussed in the last lecture, atelectasis, oxidative stress, it can cause some peripheral vasoconstriction, worsening of hypercapnia in COPD. So controlled oxygen should be given. By mistake it has been written in controlled oxygen delivery, it would be uncontrolled oxygen delivery devices. Sometimes there can be morning headaches and tiredness. So when to follow up people who have been started on LTOT? So these guidelines are British and US. First thing, the decision has to be taken depending on the availability of a nearby healthcare provider. In India, you need to ask them to come early, otherwise first follow up should be done at 3 months and subsequent follow up every 6 to 12 months to assess whether the patient requires LTOT on a long term basis or not. These are the references. Any question on long term oxygen therapy if you want? Yes.
Very comprehensive. Again, this is something which we see on a day-to-day basis. You see, in COPD, there are only two things that improve survival. One is if you stop your smoking, and the other is LTOP in the appropriate patient. বাকি যেগুলো আমরা সব করি, inhalers, nebulizers, theophylline, that they improve symptoms. But stopping smoking is very important. Only if you stop smoking and you meet the criteria, you get LTOP, and that prolongs survival. The assessment for LTOP should not be done during an exacerbation. So patient যদি hospital ভর্তি হয় an exacerbation নিয়ে ওই blood gas দিয়ে আমরা assessmentটা করব না। সে একটু ভালো হয়ে গেছে তারপরেও না। তখন পেশেন্টকে যদি অক্সিজেন দিয়ে বাড়ি পাঠাতে হয়, that is like symptomatic treatment of his hypoxia. So the patient should be at least a few weeks away from an exacerbation. And we need to repeat the ABG after 2 weeks. দুটো ABG থাকবে এরকম তখন আমরা, because it's a lifelong decision for most people, যাদের একবার it's an expensive thing. The second thing is that some patients with COPD are sensitive to oxygen. আমরা বলেছি যে অক্সিজেন দিলে একটা CO2 রিটেনশনের ব্যাপার কিছু পেশেন্টদের হয়, তাদের তুমি একটা লিখে দিয়ে বাড়ি বাড়ি দিলে কিন্তু হবে না, তাদের অক্সিজেন দিলে তাদের CO2 বাড়ছে কিনা সেটার একটা অ্যাসেসমেন্ট করা লাগে। So either you get the patient in your daycare, একটু অক্সিজেন দিয়ে কয়েক ঘন্টা দেখা, একটা রুটিন এবিসি করা করতে হবে। সেটা যদি হয় তাহলে শুধু অক্সিজেন দিয়ে ছেড়ে দেওয়াটা আনসেফ হয়ে যাবে। The other thing is মানে question is whether you send them out with oxygen or cylinder. এটা একটা কষ্টের ব্যাপার আছে। The thing is that LTOT is, I think you mentioned about 15 hours a day, MRC trial, etc. 15 ঘন্টা দিনে শুনতে খুব ভারী লাগে, কিন্তু সে যদি ঘুমায় 8-10 ঘন্টা হয়ে গেল, বাকিটা একটু একটু টিভি দেখার সময় একটু এটসেট্রা একটু লাগিয়ে 14-15 ঘন্টা পেয়ে যাবে। সিলিন্ডারে কুলাবে, ওই জাম্বো সিলিন্ডার লাগলেও 2-3 দিনে সব শেষ হয়ে যাবে। ওগুলো চেঞ্জ করা আবার নিয়ে আসা, cost wise also it is not effective. So you need to get an oxygen concentrator. দুটো জিনিস হয়, যে একটা অক্সিজেন কনসেন্ট্রেটর তো বাতাসটাকে টানে, নাইট্রোজেনটাকে বাদ করে অক্সিজেন ছাড়ে। It is warm oxygen at room temperature. অনেক পেশেন্ট বলে যে আমি হসপিটালে অক্সিজেনটা অনেক ভালো, because that comes from liquid oxygen, so it is cold oxygen, so it feels nice. গরমকালে ঠান্ডা জল খাওয়ার মতো, it is more satisfying than the warm oxygen. কিন্তু what we are interested in is giving the oxygen. আরেকটা প্রবলেম আমরা ফেস করি যে এই ডিভাইসেস গুলো এই 4 লিটার 5 লিটারের বেশি অক্সিজেন দিতে পারে। সো দোজ হু হ্যাভ মোর প্রোফাউন্ড হাইপক্সিয়া, তাদের অনেক সময় এগুলো কোপ করে। There are heavy duty machines available, but they're terribly expensive. One way we have sort of short circuit, can get 2 machines and connect them together and get a little bit more. But again, that is also a cost issue. But yeah, this is something which every stable COPD patient should be assessed. অন্যান্য ক্ষেত্রে আমরা দিই, but this is the situation where it definitely improves survival. Thank you.
Thank you, sir.
Suppose we compare between oxygen cylinder and oxygen concentrator, what is the FiO2 delivered by oxygen concentrator when we compare with oxygen cylinder?
So oxygen cylinder, oxygen cylinder delivers 100% oxygen. So the FiO2 will depend on the flow. The problem with concentrators is when you increase the flow, by default the FiO2 reduces. It's written here only. Most of the concentrators have it written in the kit insert that they give. Usually 1 to 2 liter, the FiO2 is on the higher side. If you increase the flow, the FiO2 reduces. It's around 80% the usual oxygen concentrators. I am giving you the data. I used it during COVID times. After that, I have not used concentrators.
So there's no way to measure the FiO2 that you're generating. You're just giving a flow. So you measure the patient's saturation and see if they are achieving the whatever desired saturation. In COPD patient, I mean, you don't even always need 92%. You might be happy with 90% or even 88% or something like that. But you require some sort of
flow fully you can achieve the values of 80%.
No, sir. The 80% I was talking about is the 80% in the air that it is delivering. Then you have mixture of air from the environment. Then the FiO2 falls down. Somebody requiring 28 to 32 would be a practical guess.
Nasal cannula, say you can't get more than that anyway. And as I said, it depends on the patient's respiratory pattern. I mean, if somebody is that hypoxic, then obviously we are talking about a chronic stable patient who is a little bit hypoxic.
Sandeep, all these patients are far off, and most of the time the caretaker is their family member. Sometimes even though they are not there and patient is on himself. Is there any clear-cut protocol? How are they going to titrate this machine? Because for them there is no medical support around. One. Second, do we really wean them anytime or we don't?
Sir, those patients, especially of COPD who require LTOT, so they have got damage to their lungs beyond a certain age. There is emphysematous change, maybe some bulla and all. So yes, we'll reassess after 3 months. Sir, as sir said, after 2 weeks also we'll do a ABG and all, and to assess whether the patient continues to require LTOT or not. If there is some improvement, then we'll reconsider it. Whatever little I have used, it's like once it started, it's like wearing glasses. Okay.
If you properly assess the patient and prescribe the NSAID, you very well assume that it is for lifelong. See, the thing is that if you have a good aggressive assessment policy and prescription policy, then you will have a lot of patients who are walking around, etc. Oxygen concentrated you provide them long tubing, through একটা connection আছে, টিভির সামনে একটা connection আছে, বেডে একটা connection আছে, and they are not, তুমি যেটা ভাবছো সেটা the sick ICU patient যারা অক্সিজেন নিয়ে বাড়ি যায় তাদের, that is a different category of patients.
And so second part regarding these guidelines, sir, I am at loss. I don't have that idea, but people who are on LTOT and who stay alone or who do not have a caregiver who can take care of other things, I think it's difficult for them.
Sorry?
So it would be difficult for them to manage everything, sir. Those who stay alone and are on LTOT, it would be difficult. Because
support is required. See, there are patients who, I have seen patients who carry portable oxygen cylinders and on holidays. I mean, holidays, but those sort of support systems are not available with us. But we are talking about chronic stable COPD who meet the criteria for LCHOP, and we are giving it to them for preventing complications as a result of pulmonary hypertension, pulmonary and prolonged survival. We are not talking about moribund patients who cannot get out of bed and are on oxygen for survive.
Yes, sir. So now I would shift to our next topic, that is non-invasive ventilation. I would be a little fast in this because it's 2:15 already. So what exactly is NIV? This is mostly for the residents and the nursing staff. So NIV is a technique to augment spontaneous ventilation, that is providing ventilatory support using a tight fitting nasal or an oronasal mask or a hood without endo or orotracheal intubation. This much we all know, the technical terms, it's a big sentence, but it's like augmenting the respiration by putting some mask and giving air under some pressure. So what we need to remember is that in order to apply NIV, we should not delay time to intubation in people who require intubation at the outset. Okay, suppose we have a case of exacerbation of asthma, is retaining carbon dioxide is 50-55 now, and somehow we ended up misjudging it. A 18-year-old girl, we thought it might be a COPD, and we started off with NIV. It should not happen. Okay, and with other things also, we'll go into the contraindications and all. If the patient requires intubation, the patient requires intubation. We should not delay it much. So there is a confusion regarding the modes when I go around with the residents, so I thought I'll discuss it. So there are two modes of NIV. One is CPAP, that is continuous positive airway pressure mode. That is, the pressure is same throughout the breathing cycle, be it inspiration or expiration, the pressure would be the same. The second is bi-level positive airway pressure, that is BiPAP, where the pressure during inspiration will be different and the pressure during expiration will be different. I would specifically like to mention is that our machines, the NIV mode is a CPAP mode with pressure support. So the moment we see CPAP, we get a gut feeling that the patient is on CPAP, but there is a pressure support also. So now it's a BiPAP because the inspirator pressure is a higher pressure The pressure support we set somewhere around 10, 12, 14, whatever, and the PEEP is the lower pressure. So it's practically a BiPAP. So we should ensure that in our notes we are mentioning it as BiPAP, not as CPAP. Okay, because the ABG and a mention of CPAP will not corroborate 5 years down the line when we open the file. Okay, so we have to be very clear about it, that even with a setting of CPAP, if you are applying some pressures, extra pressures during inspiration, it becomes BiPAP. Okay. Now the most important thing, in order to use a NIV, we should ensure that the patient is breathing spontaneously. A apneic patient, you cannot use NIV. Sometimes what we see is that the machine is showing apnea ventilation. Okay, that is a troubleshooting thing. We'll check it. It's not that the patient is in apnea, but there are some issues with the machine. We need to correct it. Okay. Now, because we use NIV so much, I straight away go to contraindications first. Then we'll go into the indications. So, what are the contraindications? First is inability to protect the airways. That is comatose patient. There is some upper airway obstruction. Patient is confused or agitated, or the patient has had a CVA. Now there is something dubious in this, because most of the patient with type, you'll get a, madam, I'll give you the soft copy, no need to take pictures. So the problem is, most of the patient with type 2 respiratory failure at least will be drowsy in some form or the other. Okay, so you have to meticulously decide whether you want a NIV or a proper IMV, that is intubation and mechanical ventilation. Patient who have hemodynamic instability, uncontrolled arrhythmia, those who require very high dose of inotropes, those who have had recent AMI, we should not use NIV in them. People with life-threatening hypoxemia, when the saturations are quite low, the PaO2 is very low, no point wasting time on NIV under such circumstances. People having copious secretion, then also will not be using NIV, because the problem will be those secretions will go into the lungs after that. Now some relative contraindications are there, which are facial abnormality, facial burns, facial trauma, claustrophobia. It's a very practical problem, claustrophobia. We all neglect it, because the moment we write start NIV, the nursing officer goes, puts up a tight fitting mask on the face, and we start. It's not easy to start. It's like when a car is driving at 120 or 130 km per hour, you pull your head out of the window. The kind of air pressure you feel, the patient will be feeling that kind of air pressure throughout. So there is a way to start NIV, which we do not follow. We'll discuss it today. So there are other contraindications. First is non-availability of trained medical personnel who know how to use NIV. And we will not use NIV obviously in patients in conditions where NIV is not shown to be effective. Now we'll be talking about acute respiratory failure, because most of the patients we get here are acute respiratory failure and NIV is indicated. So when will we be using NIV in acute respiratory failure? So good quality evidence is available only for two diseases. One is acute exacerbation of COPD, be it at presentation or be it at weaning, and second is acute left ventricular failure with pulmonary edema. Okay, these are the two indications where NIV will give you a really good result. I am talking about BiPAP. Okay. The others are where it can be used, but the evidence is intermediate or low quality evidence. They are acute hypercapnic failure and obesity hypoventilation syndrome. Acute hypercapnic on a background not of COPD. Okay. Mild ARDS, neuromuscular diseases, post-op respiratory failure. Sometimes in pre-intubation we try to give oxygenate using NIV. Post-extubation respiratory failure in COPD. In do not intubate status, because we don't have anything else to do, pneumonia. Okay. So what are the clinical criteria for using NIV in a case of acute respiratory failure? First of all, it will depend on the nature of the disease and patient. After that comes the other criteria, that is moderate to severe respiratory distress, tachypnea, a respiratory rate of 25 or more, use of accessory muscles, like Dr. Mitra was talking about nasal flaring and all, abdominal paradox, pH of less than 7.35, PCO2 of 45 or more, and PaO2 by FiO2 ratio is less than 300 or SpO2 less than 92% with a FiO2 of 0.5. Again, it will depend on the disease, like especially in respiratory medicine, a PaCO2 of 45 with COPD, I will be happy, but a PaCO2 of 40 with bronchial asthma exacerbation, you need to intubate probably. So the indications for intubation will mainly depend on the clinical criteria. Sleep apnea, I had decided I will speak today, but because of time constraints, today I will not be speaking about sleep apnea and all. Now coming to interfaces, some of these were shown by Dr. Mitra. One is full face mask. It covers the entire face and it's the most uncomfortable for the patient. Second is oronasal mask. It is very commonly used. The problem is aspiration and regurgitation. Sometimes when your machine fails and if there is no backup option, there is no open valves there, then the patient will end up rebreathing his own things that he is exhaling out. So asphyxiation can be an issue. Third is nasal mask. Looks good, but the problem is there will be some nasal dryness, nasal discharge, and people like me at least who are mouth breathers, there will be loss of pressures. You will be breathing through the mouth. Then comes nasal pillow. It's mainly for OSA and for CPAP, so we will not discuss it. Coming to application of NIV, the practical aspects. First of all, we should always fine tune the patient, the interface that we will be using and the ventilator that we will be connecting through that, be it a portable ventilator, the small machines, or the proper ventilators that are being used. So correct interface has to be chosen. Prior to that, the patient must be counseled about the things we will be doing to him or her. So for portable devices which are available, we will use either the spontaneous or the spontaneous timed mode. So the spontaneous mode is when the machine will assess the patient is trying to breathe in and it will push in the air, and the timed mode will be other than spontaneous, with a specific gap of some seconds the machine will be delivering. For conventional modes, we will be using pressure support or pressure control mode, although volume control mode can also be used. The advantage of using pressure targeted mode is it will be taking care of the loss of pressure or air leak, whatever is there. So the preferable mode should be the pressure control mode, but you can use volume control mode as per your discretion. So there is something called backup rate. It should be set. It should be 3 to 5 less than what the patient is breathing in per minute. Now we will be talking, keeping COPD in mind. The other things we will be discussing in between. So I/E ratio, to start with, we will be setting it as 1:2. For restrictive diseases, it may be 1:1 also. So rise time is the time when the machine takes to rise from EPAP to IPAP. For COPD, it would be 100 to 400 milliseconds. For restrictive diseases, it will be more, because if you go in fast, there will be chances of barotrauma because your lungs are stiff. The maximum inspiratory time for COPD will be on the lower side. It would be 0.8 to 1 seconds. It's always better to start on a lower pressure and slowly build it up. So it's better to start with EPAP of 2 to 4 centimeter. 4 centimeter is a reasonable guess, and IPAP of 6 to 8. The difference between IPAP and EPAP should be at least 4 centimeter of water to begin with. Now for the nursing staff. Initially you should put the mask on the face for some time. Let the patient get used to it, and then you apply the mask. When you are keeping it on the face, that is the time when you can match your EPAP. You have to set it, because sometimes what happens is, even when the patient is trying to breathe, your machine is showing apnea breathing. So that is when the patient has a very high auto PEEP. Under such circumstances, you have to gradually increase the EPAP to cross that PEEP. After that only the negative pressure that the patient is generating will be sensed by your ventilator. Till then the ventilator will not be able to sense because of the PEEP. Suppose the auto PEEP is 6 and the patient is generating 4 centimeter negative. So if you subtract, it's still +2, and you have set -2 as your sense, the trigger. So the machine will not be sensing that the patient is trying to breathe in. So proper nebulizations if required, look for PEEP, auto PEEP, and to rule it out and to increase EPAP beyond auto PEEP is what you need to do. You will not be able to do it, ask your medical officers to come and have a look. Just do not neglect apnea ventilation. Okay. Usually required EPAP is around 4 to 6 centimeter of water. For obese patients, we need a higher EPAP. So how do you monitor? So first is, yes, you have to look for mask comfort. Then you have to look for respiratory distress, respiratory rate, whether there is any tachypnea, tachycardia, is the patient sweating. Look for sensorium, look for accessory muscle use, very commonly neglected, but we should look for that. And we have to see the tidal volume the patient is generating. We'll not be able to see it in the portable devices, but with the ventilators we will be able to see it. It should be around 5 to 7 milliliter per ideal body weight, okay, kg. And we should check the ABG at baseline, then 1 hour after intubation, then on an as needed basis. But we should check it after 1 hour. So when to discontinue NIV and go for IMV, that is invasive mechanical ventilation. So first is NIV failure. When in spite of everything whatever you have done, the patient continues to deteriorate, there is some hemodynamic instability, saturation is not getting up, pH is deteriorating and CO2 is progressively rising up. Second is worsening of mental status, deterioration of pH and PaCO2 as we discussed, and refractory hypoxemia. Under those circumstances, intubate if required. And again, if the patient is not able to clear the secretions, you have to intubate, because otherwise the patient will drown in his own secretions. It was a very fast and simple description. Any questions if you want to ask? Sir.
Thank you, Mike. Very excellent, very nice. See, the most important point you made is the first slide. You had written that application should not be to be the intubation. The case selection is very important. There is evidence that those patients who you put on NI and if they fail and then you have to go to IMC, then their outcomes are a bit worse. Over the last many years, people have gained a lot of experience in NIV, and NIV has saved a lot of lives. NIV has saved a lot of patients from intubation and intubation associated ventilator associated pneumonia, etc. So we are using more and more. So intubation থাকবে যে NIV চলবে, intubation থাকবে যে না একে ইনজুয়েট করতে হবে। মাঝের কয়েকটা পেশেন্ট কিন্তু থাকবে তাদের NIV দেবো কি দেবো না। If you are prepared to sit by the patient for the next hour or two, then go for NIV. After the failure is going to দেখো, the patient is not tolerating oxygen mask তুলে দেবে, থামবে, tachycardia হবে, desaturate করবে, agitate খুলে দিয়ে intubate করবে. But if you cannot be by the patient's side for the next hour or two, then you may go for intubation. Intubation ventilation করার সোজা, sedate করে দিলাম, dialysis করে দিলাম, ventilate করে দিলাম, patient চুপচাপ থাকবে। কিন্তু NIV তে patient জাগা, কষ্ট আছে, শ্বাসকষ্ট হচ্ছে, so it is a bit more difficult to handle. And in machine, if you are in ICU, good, because you've got the NIV mode in the Bosch machines, and you have got all the features. But if you're using a basic ছোট্ট machine, ওখানে ওই i5 টিপের ছাড়া কিন্তু কিছু নেই বেশিরভাগ সময়। একটা প্রবলেম অনেক সময় হয়, যে পেশেন্টের রেজোনার মাস বা কোনো চলছিল, সে স্যাচুরেশন মেনটেন করছে, কিন্তু পেশেন্টের CO2 বাড়ছে, ইউ ডিসাইড টু গো ফর NIV। NIV তে এই ছোট মেশিন দিয়ে দেওয়া হলো, পেশেন্টের দেখলো যে স্যাচুরেশনটা কিন্তু মেনটেন করছে। এটা is something that you have to appreciate. যে বড় মেশিনগুলোতে there is a oxygen line, there is a air line, there is a blender, and you can give FiO2 of 80, 90, 100% oxygen. ছোট মেশিনগুলোকে এইটার সুযোগটা নেই। either ওরা বাতাসে NIV হচ্ছে, or you put an extra tubing and entering oxygen from the oxygen thing on your wall, which is only maximum of about 15 liters. ঠিক আছে? আর এই যে flow যেটা যাচ্ছে NIV তে, it is like 30, 40, 50, 60 liters a minute. So it is getting very diluted. So though you are gaining in the pressure, you are losing on the FiO2. সেই জন্য অনেক সময় হবে যে ছোট মেশিনে পেশেন্টদের দিলে স্যাচুরেশন মেনটেন করতে অসুবিধা। So you might want to consider using the bigger machine, কিন্তু সেটা obviously water coming a little off. Thank you. Is that what you see face as well? আমাদের ওখানে ছোট মেশিন তো আছে, সুবিধা হলো সস্তা, অনেক পেশেন্টদের হয়তো আইসিইউতে যেতে হয় না, আইসিইউ থেকে তাড়াতাড়ি নামানোর জন্য ওয়ার্ডে দেওয়া যায়। But you have to be familiar. মানে যে কোনো মেশিন you have to be familiar with the knobs, you have to be familiar with the settings, and you have to get comfortable with it. মাঝরাতে শিখতে বসার ব্যাপারটা কিন্তু হবে, আগে থেকে দেখে রাখতে হবে।